the difference between degenerative retinoschisis and the retinal detachment, and looking at zonular tufts, meridional folds and meridional complexes, we are coming to white without pressure. Now white without pressure without a vitreoretinal traction is benign, so we don't need to worry about it, but with vitreoretinal traction, yes, it is worrisome and it predisposes to the retinal detachment. White without pressure is a common peripheral retinal finding characterized by translucent white gray areas of retina seen without scleral indentation. So without scleral indentation is seen, that is why it is white without pressure. Usually located posterior to the vitreous base, often bilateral and more frequent in myopes. It represents altered vitreoretinal interface or the optical phenomenon rather than the true pathology. By itself it is benign, as I had said. So however, if it is associated with traction or adjacent lattice, then we have to, it is an indication of the treatment and it warrants careful follow-up. So this is how a white without pressure area looks. The white arrows point towards the white without pressure area. So there can be multiple white without pressure areas commonly seen in moderate to high myopes, myopic patients. Now operculated hole, operculated retinal, yes.
So as rightly mentioned, so white without pressure areas, so these are actually the appearance is like a white without a whitish appearance. So it is the indication, so when they have gone into the research, they have said that the reflectivity of the outer retina is higher than the peripheral, than the remaining retina. So that's why it appears whitish. So because of the reflectivity of the normal retina, the reflectivity is higher than the, yeah. Thank you.
White without pressure area is seen, but the most important thing that you have mentioned, that whether to layer them or not layer them. So it's very important for every one of us, Dr. Nipun, what are the indication for layer these areas if they are associated with lattice or holes? Can you just say a few words about that?
So white without pressure areas, as mentioned by Dr. Aishwarya, it is benign, but if it is associated with any retinal breaks, traction or lattice with holes, then it is an indication for a barrage laser, particularly prior to any kind of surgery. Yeah.
Thank you, sir. Now, operculated hole. An operculated retinal hole is a full thickness retinal defect caused by focal vitreoretinal traction. A small plug of retina is avulsed and remains attached to the posterior hyaloid. So that becomes the operculum. So in an operculated hole, the vitreoretinal traction is relieved, but a part of it just remains. It is attached to the hyaloid. So the risk of RD is low. Okay. So, and in the horseshoe tear, the traction is persistent. So hence it is an urgent risk to barrage it. These are many peripheral retinal degenerations and also the complications of those degenerations. As you can see from avulsion of the vitreous base, then dialysis, retinal dialysis, retinal tear at the anterior border of the vitreous base, horseshoe-shaped retinal tear. Now this is important, as seen in previous slide, that operculated hole is better and horseshoe retinal tear has to be addressed immediately. Then tear with operculum in overlying vitreous, so the whitish thing above it is the operculum. And then horseshoe-shaped tear in equatorial zone, so, and then lattice degeneration with holes and atropic holes. So just a diagrammatic representation schematic of the degenerations we just saw in the previous slides. Now,
What is the most common among which most common?
Sir, according to me, the most common degeneration is the lattice degeneration. It is seen most commonly in high myopes and also in patients who are not myopes but who undergo thorough retinal examination, posterior retinal examination. In those, lattice degeneration is seen commonly.
And which is more serious? Is HST?
HST, yes.
Horseshoe tear.
And the lattice degeneration most commonly seen in which quadrant? Like this is a theoretical question, but yeah.
It is seen in the superior and temporal quadrant.
And even in the inferior-temporal and
Temporal.
HST is more, you need to immediately.
Immediately, it is an emergency because if it is associated in the located in the superior temporal quadrant, then we need to barrage it as soon as possible because within 2-3 days it can progress to retinal detachment, rhematogenous with macula off. Yeah.
So that's very important thing.
Thank you, sir. So now the benign degenerations. Now white with pressure on indentation, then peripheral cystoid degeneration, paving stone degeneration, peripheral retinal lucence, reticular degeneration, and diffuse peripheral RP degeneration. That is RP, mottling, and atrophy. So this is the white with pressure. We can see the peripheral white, yellowish white areas. Mostly the folds are coming because it is seen on indentation, hence with pressure. Now this is a paving stone degeneration. It is also commonly seen. It is a benign peripheral degeneration. It is characterized by well-demarcated area of chorioretinal atrophy, but seen in the far retinal periphery. And there is a focal loss of retinal pigment epithelium and outer retinal layers. It is located between the ora serrata and the equator, hence in the periphery, and it's common in the inferior quadrant. And it does not predispose to retinal breaks or rhegmatogenous retinal detachments, hence it's benign. So on the picture A shows the lucence, peripheral retinal lucence. We can see the picture B shows the central retinal lucence. Just to compare with the picture A that shows the peripheral lucence. And on the picture image, it is the paving stone degeneration that is seen with the chorioretinal atrophy, which is very prominent. Now, what are the complications? The complications are retinal breaks. It can be holes, horseshoe tears, as we have seen previously, rhegmatogenous retinal detachments, especially with horseshoe tears. It is very quick. And vitreoretinal traction events, that if it is a persistent vitreous adhesion at the lattice margin, there can be a traction which can lead to retinal tears and progressive enlargement of the breaks. Then vitreous hemorrhage if the lesion is associated with the vessel. So that time it can also cause the bleeding. Then retinoschisis related complications and increased risk during ocular trauma, gap cap, cataract surgery, or any anterior segment related surgeries. So on this image, on the left hand side, we can see the horseshoe tear, little blur it is. So on the right hand side, a better picture of the horseshoe tear can be seen. This is the giant retinal tear, rhegmatogenous retinal detachment. We are showing the giant retinal tear. It is also complication of the peripheral retinal degeneration, high risk peripheral retinal degeneration. This is the retinal dialysis, more perfectly seen in the right sided image superiorly. This is the retinal dialysis. And now a short brief summary of the lattice snail track high risk peripheral retinal degeneration and its association. So the lattice snail track degenerations, they are usually seen in high myopes. High myopes have a long axial length and with posterior vitreous detachment, and it is a precursor of the retinal detachment. And the retinoschisis, cystic traction tufts, they are seen in older age as such as degenerative. We are talking about degenerative retinoschisis here, and also myopia. And they also progress to retinal detachment. And benign, that is paving stone, white without pressure, without any vitreoretinal adhesion, and white with pressure, common in general population. Even paving stone degeneration, they have no risk. They are a common finding, just to be monitored in follow-ups. So, a chart showing us the clinical situation and the prophylactic treatment needed, as told to us by Dr. Nipun sir. This chart has been taught to us by Nipun sir, and we have just compiled it and posted it. Lattice degeneration in an eye and occasional floaters and flashes. It is a asymptomatic lattice, so there is no need to prophylactic treatment. Lattice degeneration without retinal hole in an eye with recent onset floaters and flashes. So meaning this lattice is symptomatic. So yes, we need to go for a prophylactic treatment. And if there is a lattice degeneration, and as sir has discussed, if the patient is going to undergo any kind of surgery or any procedure, then yes, we need to do prophylactic management. Then lattice degeneration in an eye with no symptoms and a past history of blood trauma, then no need. Just a past history doesn't warrant, but so symptom is one of the main things, and prior to surgery, yes, even without symptoms, we should go for a prophylactic management. Then there is a retinal break, then yes, we need to go for a treatment. Lattice degeneration without retinal holes or tears in an eye with no symptoms and fellow eye showing RD. Lattice degeneration So this is important. Fellow eye is already is showing RD, and the other eye has lattice degeneration, but it does not have a retinal hole. There was a recent patient nearly 10 days back who had come with a similar picture. He had a bullous retinal detachment superiorly, and the other eye had shown multiple 2 to 3 lattice degenerations. So we barraged the other eye, and he underwent right eye RD surgery, if I'm not wrong. And lattice degeneration without retinal hole and no symptom in a single-eyed patient. So this is very important because it is a one-eyed status. Then even without any symptoms, if we should manage it prophylactically, shouldn't wait for the symptom or the hole to develop. Lattice degeneration without retinal hole and recent onset ptosis factors in a single eye. So, and mostly syndromic patients like Stickler syndrome or Marfan syndrome, who are usually high myopes, they need to undergo prophylactic treatment. Then multiple rows of lattice degeneration involving 360 degrees of retinal periphery. So now the lattice is quite extensive. In such a, even if the patient is asymptomatic, it would not be advisable to wait for a follow-up or to wait and follow the patient. It is good to prophylactically barrage the patient. Now, lattice degeneration in a patient planned for VR surgery for a full thickness macular hole. So here the patient is undergoing a macular hole surgery. So that time, if the lattice degeneration is observed, even intra barrage can be done. Now, peripheral. Yes.
So in a nutshell, for the fellows, so in a nutshell, any lattice degeneration or any snail track degeneration, if you have any symptoms of flashes and floaters, first thing, and second thing, if you have any vitreoretinal traction or break associated with it, then those are precursor for retinal detachment. Third thing, if any family history of retinal detachment is there, or other eye has undergone retinal surgery, retinal detachment surgery, and this eye has even asymptomatic retinal holes, then you should prophylactic barrage them. So these are the indications. And eyes undergoing any cataract surgery, intraocular surgery, refractive surgery, or even YAG capsulotomy for any small procedure also, then you should prophylactically barrage them. So, and horseshoe tears are independent of this. Horseshoe tears, it is an emergency because it is invariably associated with subretinal fluid, which can progress to rheumatogenic retinal detachment very fast. So you should barrage them. So these are the few important points.
Thank you so much, Dr. Nipun. For NTA segment surgeon point of view, many times myopia cases who develop cataract, because cataract is more common in myopia, and in addition to cataract, they can develop the glaucoma and also retinal pathology, as discussed very nicely by Dr. Aishwarya. So what I have seen that many times anterior segment surgeons, they don't have pain to examine the retina, they don't examine or refer them for retinal examination. And once you see them, there are few signs, like once you see on the slit lamp, I have seen few cases where there was tobacco dusting sign, and once we examined the retina done by Dr. Nipun, there was HST. So Mr. Rakesh sir, who came from, who was working as a partner, district collector, so he came for cataract surgery, and I saw in the OPD, and there was tobacco dusting sign, and he had big HST, and which was lasered immediately. So how common these signs are there in these pathologies, particularly what they indicate, like tobacco dusting signs or something like that?
Very true, sir. So in a dilated patient on slit lamp, even if we see the behind the IOL or behind the cataractous lens, these tobacco dust or any vitreous opacities, then the peripheral retina examination is a must. And particularly whose this thing number myopia is very high, or -4 to -6. And one this thing irony is that when we see practically in patients, very high myop patients, the probability what we see in moderate myopia, we are finding the peripheral retinal degenerations, probability of finding them is very high as compared to the high myopia. But yeah, definitely we see in high myopic patients also with the peripheral retinal degeneration. So this tobacco dusting sign, this Schaffer sign, which is called this on the anterior slit lamp examination, is a very good sign, a very good indication, so that chances of any peripheral retinal degeneration can be present. So they should be referred to a retina specialist for a peripheral thorough retina evaluation. Thank you.
Thank you, sir. Sir, additionally also, if there is any history of trauma previously to that eye, and if some signs of the trauma can be seen, like a corneal scar, then we can go in retrospective and see, ask the patient if there was any trauma.
Yeah, very good point. Any shuttlecock injury or any tennis ball injury.
That's very important point you have highlighted, Dr. Aishwarya. I have seen many cases while doing cataract surgery that suddenly I am just doing irrigation, phacoemulsification, one part of the journal cells capsular baggage coming to the phaco tip, particularly while we do the last piece. So when I asked yesterday only, I did one case when I asked this lady that did you have any sign of trauma, like did you have any trauma, like the case which you saw, we both saw also. That lady also, when I asked her, she told me that 20 years back she was hit by the remote. So when I did transplant material, it was very difficult case. It was really difficult. There was very shallow in the chamber. I was not knowing what is going on. There was poor corneal opacity. Because of corneal opacity, there was poor visibility also. So when she came first day, I did transplant material strip also just to deepen the entry chamber. So she was seeing nothing, PLPR. So her son was very worried, and she was not worried, but her son was very worried. And when I asked her that, I told her about this remote trauma, her son was not knowing about this. So many times, on the table we realized that this was a case of trauma. And then she had some material hemorrhage, and that was cleared, and then her vision was improved. So that's very important point you have mentioned. Trauma is very important. Trauma is not uncommon in India. Many times, the grandparents can, while holding the child, it can hit their eyes, and there can be trauma with the festival-related trauma. So, thank you so much.
Thank you, sir. Now, the peripheral retinal degenerations, indication for prophylactic treatment, once again in short and brief, with recent onset flashes and photos, lattice degeneration with a retinal hole, retinoschisis with retinal detachment, also retinoschisis with retinal holes, horseshoe tear or retinal dialysis, retinal hole with cuff of SRF, subretinal fluid, traumatic breaks, in patients undergoing refractive surgery, cataract surgery, degenerations in fellow eye of an RD patient or in a single eye patient, and syndromic patients like Marfan syndrome and Stickler syndrome. So this is a fundus picture of the Stickler syndrome patient with multiple peripheral degeneration, and also there is a barrage mark seen on the right hand side. Now, what is a Stickler syndrome? The definition is it is a connective tissue disorder which is hereditary, associated with ocular, auditory, skeletal and craniofacial involvement. It is autosomal dominant. So also family history is important, and the gene mutation is called LA2 gene. Key ocular feature is abnormal vitreous, optically empty membranous vitreous, high myope, early onset. Lattice degeneration is the most commonly seen in peripheral retina, and complication as can go into retinal tears or early RRDs. Lens changes, early onset cataract, and then auditory features, skeletal features and cranial facial features are also associated. Now it has a very high lifetime risk of retinal detachment, hence prophylactic laser is advised even for asymptomatic lesions. So this is how the prophylactic laser has been done. As you can see on the left hand side, the lattice has been barraged, and there are many laser marks also seen. So this is also an image of the patient with Stickler syndrome post-barrage. Thank you. I'd like to conclude the today's topic of peripheral retinal degenerations and leave it for discussions. Thank you so much.
How one should differentiate between subclinical RD and retinoschisis other than the presence of the retinal hole? Because sometimes in subclinical RD, when the lesion is very anterior, it is very difficult to locate. So how we should differentiate between these two?
Yeah, that's a very nice question. So in retinoschisis, what happens is there's a splitting of the retinal layers. So when we do a B scan, there is a single dome-shaped spike on the B scan with an single A scan spike which is very uniform and which is low in reflectivity as compared to a retinal detachment which has a high reflective constant spike, and it is attached to the optic nerve. In case of retinoschisis, it is mostly inferotemporal and a single shape spike. And there is one barrage, there is a spot test also, but not in all cases, because we tried in one case at barrage laser spot test, that if we put a laser on the laser mark on the periphery of the retinoschisis, it will take up the laser. But in case of the retinal detachment, because the retina is detached, it will not take up the laser. So there are 2 points which we can differentiate. And the third thing is that the scotoma, like if you tell the patient to you depress with the scleral depressor, and you tell the patient to see the shadow of the lens in that area, so he'll have an absolute scotoma in case of a retinoschisis, but a relative scotoma in case of a retinal detachment. So these are the 2-3 points to differentiate between retinoschisis and retinal detachment.
Mr. Gupta sir, who has witnessed the era of ICC, the era of ACC, the era of SICS, and the era of femtosecond, and finally the era of robotic cataract surgery. So I would like to request Dr. Gupta sir to say a few words about this revolution and evolution of cataract surgery. Dr. Gupta sir, please.
We are used to do ICC. Usually we are doing surgery. So there was no retina was there backward past this time. Now retina is fastest growing branch of ophthalmology due to newer techniques, newer diagnostic methods, newer injections, and newer surgical procedures. So one must remain updated in retina. The same is very useful for this time. Thank you.